So let's continue. So what I told you is that there's different ways to, once we have the information from a projection, so we measure the sinogram. So the sinogram is exactly what we measure. So in order to then to reconstruct the original distribution of attenuation coefficients is what we actually want, so which is the image, so which is the cross-section through the body. So we have these different ways to do that. One is the regular back projection, which works nicely, but is a smoothed version, so it's not a correct version. Then we have the theoretically correct Fourier-based version, where we have the problems of the calculation in some ways, so especially the interpolation is potentially a problem from Cartesian or from the polar to the Cartesian coordinates, but with filtered back projection, we can manage that. But with the disadvantage that although it's theoretically correct, it also theoretically kind of reconstructs all the artifacts and all the problems, all the noise, all the non-ideal parts of the machine. And so then thirdly, we have a way is like the iterative reconstruction, where we find the highest or the most likely distribution that would lead to the measurement that we have. So here you see this in a way graphically illustrated. So this is how we go from the projections to the ultrasound image. So say that here on top, this was the distribution. So this would be the cross-section that we want to measure. So we're going to make projections from all directions. And what you see is if we do back projection, so here you see how crucial it is to have kind of the projections from all these different angles. So the more projections we collect, so the more we add projections to the back projection, in this case the filtered back projection, the closer we will come to the original object. And here is the iterative reconstruction, where you see that we start from just a gray disk, and then we're going to refine more and more in order to resemble more and more the original image. And here you see this is a filtered back projection of a real image. So where you start to see that the more information you add, so the more angles you add, the better you can get. So what we see here, as I said before, iterative reconstruction has the advantage that it can reduce artifacts, has the disadvantage that it's computationally intensive, and also has the disadvantage that since theoretically it's not a one-to-one correspondence, you're not saying like reconstructing exactly what was measured, you just reconstruct what was likely measured. So obviously in a real scanner, it's most often that the likely is better than the real theoretical, although it might lead to some artifacts then later on also. And of course also, it really depends on how long you iterate. So because you see that it becomes better and better the more you calculate. But of course you have to stop at some point. Okay, so this is how we get these images. So now you know how you can, from having projections from all different angles, you can come to a reconstruction of what's the distribution of attenuation coefficients that led to it. So keep in mind, this is also what I said in the beginning. So what you do is, with a CT scanner or with an X-ray scanner, what we measure is we measure distribution of attenuation coefficients. We know that that is related to the local distribution of atoms in the object. And we then assume that this atom distribution is related to the anatomy, which obviously it is, but keep in mind that you always take these different steps. So what you measure is attenuation. You don't measure anatomy directly. Okay, so how do we make this then further into a scanner? Because what we want is, of course, mostly scan a part of the body, or potentially even full body. Although with full body scans, of course, the dose can become very, very high. So you have to be careful for that. But what you mostly want is you don't want just one slice. What you need is you want several slices. So the first type of CT scanners, what they were is they were a single slice CT scanner. So that means that we had a source, we had a detector, then the patient would slide in the scanner, and then we make one cross section. We do reconstruct it, and what we then do is then we shift the patient. So we shift the table a little bit, make a next cross section. And so by shifting the table each time and then make a new cross section, we can scan like a 3D volume. So that's what was called axial scanning. So between the different scan planes, we have a certain distance there. Keep in mind that also these slices are not infinitesimal thin, so they have a certain thickness, because of course the X-ray source that we use is a beam, is an X-ray beam, and that has a certain width. We cannot make an ideally thin beam, but of course the thicker the beam would be, the thicker the slice that we go through, and so the less the resolution, of course, in that direction. So this way we can calculate different scans and go through a full body. So keep in mind that if we want to resolve it fully, that means that then, of course, the distance between the scans needs to be less than the half the beam width. So because otherwise we would have parts of the body that we do not scan. Of course, what happens is that if we have overlap, what we sometimes do, so you can do an overlapping scan, but of course, then you increase the dose. So everywhere you overlap, you have twice the dose of the X-ray that comes through. So this is, again, a thing that you have to see what's the cost benefit from. So the thing that people then said is like to do this kind of scanning and then stopping, shifting, scanning, stopping, shifting. So let's make this a little bit more efficient, and let's do continuous scanning and continuous sliding of the table. So which is what we call like a spiral scan or a helical scan. So what happens here is we have the scanner, and in the scanner we have the X-ray source, the detector, that are constantly rotating. And while they rotate, the table is going through it with a constant speed. Obviously, that means now that every projection that is being taken, so every angle that is being taken, is of course at a slightly different position of the table, because the table is moving while we are scanning. So while you scan, every angle becomes at a different position. So which means that obviously the projections that we have are different, and we have to make sure that, first of all, we still see that we cover everything with about 360 or at least 180 degrees. That's the minimum that you need to scan in order to be able to properly reconstruct it. And then, of course, in our reconstruction algorithm, we have to take the speed of the table and the speed of the scanning into account. And so then you can do this. So this had already made the scanning more efficient. So it's and faster. In principle, you can do a lower dose in this. And what you can easily do is then kind of do a cost benefit and like how fast do I want to scan as compared to what's the kind of number of projections that we have. And so the number of degrees of projection, whether we do a 180 or 360 degree scan. And then, of course, what is the resolution that we would in the end reach? Here's a typical example of some of these scans. So this is a kind of full abdominal scan. So we start below from the pelvis, so we can stop for a moment. So you start from the pelvis. So you see here is the bone muscle, the muscles of the legs. You see there you pass through the femur. Here you see like the femur head. So this is the start of beginning of the spine. You can nicely see the muscles. You see here the rectum. You see the spine coming through. And here you start to see again what we told you before is the very typical types of tissue that you can discriminate. So we have at the one hand bone. Bone is very bright because the attenuation of bone is very, very high. So calcium attenuates a huge amount of X-rays. So what is very bright in X-ray images is mostly related to bone. What you then see is that muscle is something in between. So muscle is soft tissue, which is relatively close to water in attenuation coefficient. Then you see something which is in between, so which is a little bit darker already, but it's not as dark as the air outside. So the air outside is fully dark because air is not attenuating. So this is actually the fat layer. So this is like a fat layer which is underneath the skin. And then you see the skin itself, which is closer to muscle. And here again, what you see is, so you see here this black part. So this black is the only thing that can be black is gas or air or nothing. But obviously this is gas inside the bowels. So you can see by, even if you don't know anatomy, what I expect from you is to know is like, why is one thing bright and what type of tissue would correspond to it? And why is it black? And why can it correspond to this? So this way you can nicely see this through. And here you see already this kind of white line below. As I told you before, this is actually the table that the patient is on, because obviously the X-rays have to go through the table, although you make the table out of material which is not attenuating a lot. So it can be, in the past it was wooden tables. Now it can be tables of some kind of plastic. Obviously, you're not going to make this table out of metal, because if it would be a metal table, metal would absorb a lot of X-rays. And then, of course, I mean, you would lose a lot of X-rays when you go to the table, which of course you don't want, because that means that you have to increase the dose then in order to be able to get some useful information. So that's why you try to find a table which is solid enough for a kind of heavy patient to lie on it, but which has as little attenuation for X-rays as possible. And so then you can scan further through, so you start to see some other things. Now, one thing that you see here also is that now, when you look at it, so here we know it was black for the air, but here you start to see something which is bright also. So you see here some bright structures which seem to be within the belly. So, and when you go through it, it doesn't look like this can be a bone. So what happens is that here you start to use contrast agents, and we come back to that later on. And here you see something similar. So here you see two symmetrical structures appearing, which is clearly some organ structures. And so these are the kidneys. But again, the kidneys are bright, while they should be similar to muscle, soft tissue. So that means that some contrast agent has been used. And then you can go up. You see here the large liver, so which is a big organ. And then you come here to the heart. Now, one thing, when you look at directions, so you know that your liver is at the right side of your body. So normally, most people, so 99% or something like that of people have their heart at the left side and the liver at the right side of the body. What you see here on these images is that the liver is on the left side. And this is, in a way, a peculiarity. But this is by convention. What radiologists do when they look at scans is they actually look from the toes to the head. So you look from below and you look upside. So you always look at the cut of the body from below. And so obviously when you look from below to the liver, a person that is kind of being on their back, so you know the person is lying on the back, then of course the liver would be at the left side. So you always look from the feet to the head when you kind of do these scans. That's conventionally the way that you do it. And then you just go up through the liver, as I said before. Here you have a cross-section through the heart. So this is like what we call an abdominal scan. And of course here, you start to see the lungs. So you see that, so you go from the liver. What you then see is that the lungs start to appear here. So these are like large fields of air. And here, this is actually the diaphragm that you go through. So this way, by looking at what's the values, what's the gray values on our CT image, convert that to what's the type of material we go through. And this way, together with the position, you can actually infer what the clinical information is. Okay, Now, when you look at the most recent scanners, then what you start to see is that we actually use multi-slice CTs. And what you do now is, instead of each time just having one slice that you make with your X-ray, what you do is now you use an X-ray source, which is actually sending out a pyramid of X-rays. So not only just a fan, so that we can kind of get one projection with one shot, but now you do a pyramid so that you have like one slice and have different slices at the same time. The disadvantage of this, of course, is that you, of course, need much more detectors. So that means that for every slice here, you would need a row of detectors. Especially in the past, detectors were some of the most expensive parts, but of course nowadays, with the improvement in electronics and the improvement in kind of integrated circuit manufacturing, we can actually make larger detectors. And so that means that nowadays we have scanners with up to 265 or even 512 slices at the same time. So you can actually make, with just one X-ray block, one X-ray pulse, you can actually scan one projection of almost like a whole thorax or a whole abdomen. Of course, the big advantage of this is that you can scan much, much faster. So your scan time becomes, of course, a lot faster. The other thing is also that every X-ray is being used, so you don't have overlap of X-rays. So that means that you can actually reduce your dose. So you don't need to scan different parts in a different way. So even if my X-ray field is non-ideal, you know that isn't too much of a problem. The disadvantage, as I said before, is of course the amount of detectors and then the amount of data that you have to work with, because that's a huge amount of data which is then immediately produced. And as I said, then the reconstruction, of course, becomes a little bit of a challenge. But this is what current scanners are working with. Then lastly, what you could also do is actually use a fluoroscopy X-ray machine, as they are using in, for example, the catheterization laboratories or in the operating theater, and where they normally just look at projection X-ray, like I explained in the first class. What you can do is, if you take these X-rays, so these fluoroscopy scanners, what I told you before is that they are flexibly kind of mounted on what we call a C-arm, so that we in principle can make a projection from any direction. But of course, what we now can do also is do a controlled rotation of these fluoroscopy machines. And what we do there is, with the fluoroscopy machine, is what we, of course, is we scan a cone. And if we have a digital version, what we could do is also we can scan it and then do a reconstruction. And so you can actually do a what's called a rotational, for example, angiography, as we will see at some point, based on these machines. These machines are in principle made for real-time imaging and working with the under the images. So to do interventions or things like that, working with catheters to do surgery or something like that. But sometimes, because they're projection, sometimes you would like to have a 3D reconstruction, and then you would do it. But while a CT scanner, what you have is the X-ray source and the detector are actually moving very, very fast. They're really moving super fast because this detectors can work fast. Of course, these angiography machines, you have to slowly move because they're like open in the air in the room. So this is something like doing a CT with this type of fluoroscopy machines is an add-on, but you would never use this primary in order to do that. But again, then also, since you now have a cone reconstruction, obviously you need to adapt your reconstruction rhythms in order to cope with that. So you always need to know exactly what the geometry is of your X-ray kind of source and how the rays pass through in order to reconstruct it properly. Okay. So that's what I told you before. So all of this can use iterative reconstruction, which is better in coping with real situations, so with the non-ideal scanners, but of course it's time consuming. Now, maybe also a bit of a peculiarity in some ways is, say that we want to use a CT scanner to look at the heart. The thing is, what happens is that the heart is moving, of course. The heart is beating while we do scanning. So that means that if we have the beating heart and we know we need at least 180 degrees projections in order to reconstruct it. So that means that while the heart is beating, of course, in every position of the beating heart, we would actually need this amount of projections. Because otherwise, if the heart is beating, what happens is that the configuration or the distribution of our of our absorbent, so our X-ray attenuation, that distribution is changing. So because the heart moves, that changes. So in order to also be able to reconstruct that changing distribution, we need to measure it over at least 180 degrees in every position of this. So this becomes a little bit of a problem, and also the heart is a relatively large organ, so we have to make sure that we can cover this, and we have to make sure that we cover the whole cycle. So we need to cover it in 3D, the whole volume, and cover it in every position of the heart during the contraction. So that means that we need to do some tricks in some ways, because the scanners are just not fast enough. So we cannot scan that fast that we rotate or that we have a full projection while the heart is not moving. So the heart is moving so fast that it will have moved during the rotation. So that means that we have to find a way to do proper timing, to know not only from which position a projection comes, but also from which phase within the cardiac cycle the projection comes. And when we talk about this, so when we want to determine where we are in the cardiac cycle, obviously the most straightforward or the easiest way to do that is based on the ECG. So if we measure an ECG and we look at the morphology of the ECG, we know where we are in the cardiac cycle. So very typical, the ECG has the big peak, so it's what we call the R wave. So the R wave indicates the onset of contraction. So what we can do is we can use this peak in order to trigger. So we measure that peak on the ECG, and then we can, with regard to that peak in time, can see where we either do the measurement or where a measurement was done. So these are two ways to do it. One thing is that you can trigger the acquisition. So that means that what you do is you take a projection at, for example, this R wave. Then you change the angle, and then you wait for the next R wave in order to do another projection. And then again, you change the angle. In the next cardiac cycle, you take that projection. So that means that then after, say, if you would scan every 1 degree, then after 180 cardiac cycles, you have 180 projections in exactly the same kind of phase of the cardiac contraction. And then depending on what the temporal resolution is, what the spatial resolution is you want, what the number of projections are that you want, you can actually do this. Of course, this way you lose a lot of time. And also, if you have to measure an image, so make one image over 180 cardiac cycles, I mean, given that, and especially a normal heart has some heart rate variability, that means that always, I mean, you're never exactly at the right point. So that means that you always have a little bit of blurring from motion. The other thing what you can do is you just start scanning. So you start taking projections and you just save the projections, and at the same time you save the ECG also. So that means that for every projection that you took, you know in which position you are in the ECG. And then later on, you take all this data that you collected, and now you start to reshuffle it afterwards. So you start to see like, okay, this position of the ECG, when did I measure it? And you find the projections that correspond to that position in the ECG. And you do that the whole time. And so that is then like the kind of post-triggering. And this way, you can actually do scanning faster and more reliable. But the most important is that you have to make sure that you know where you did the scanning, so the position of your scan plane. So if you have a moving table, you have to keep that. If you have your multi-slice, which is what is currently being used for most cardiac applications, you need to know in which projection you are. And then you have to also know additionally where you are in time with regard to the cardiac cycle, so with regard to the ECG. So for cardiac imaging, the ECG is super important. First, to recognize where you are in the cardiac cycle. And secondly, to potentially trigger the acquisition to make sure that the data that you collect is from the same cardiac cycle. That means that in reality, real-time scanning with a CT scanner, so making sure that you have a full 3D image or even on the edge a 2D image of the heart within the same cardiac cycle is tricky, it's very difficult. So mostly what we do is we actually kind of acquire the data over several cardiac cycles and then reconstruct it so that we a representative cardiac cycle, let's say that. That has the disadvantage, as I told you before, is that actually the normal physiological variability in the length of the cardiac cycle will now introduce smoothing. So you cannot do better in the acquisition than this variability. That, on the contrary, with ultrasound imaging, where we can really go real time. So there we really can acquire the whole heartbeat within one cardiac cycle. We can, and knowing that it comes from one cardiac cycle. Now we have one advantage, and that is like a big advantage in cardiology, that mostly what you want to do is you want to scan sick people, of course. You don't want to scan too many normal people, especially with a CT scanner that gives X-rays. You don't want to do CT scanners in people that are likely to be normal. So we scan a lot of sick patients, and most sick patients in cardiology, they are taking beta blockers as medication, which would reduce the heart rate, so make it slow enough, and would also reduce in some way the variability of the heart rate. So actually, that's an advantage that sick people can be better in brackets scanned than normal people who might have a faster heart rate or more heart rate variability. Okay, so one of the things I told you before also is that attenuation is actually also depending on the energy. Okay? So depending on the energy of the X-ray photon that we use, your attenuation coefficient is different. So up to now, everything that I explained assumed that you would have either a kind of single energy of X-ray photons, or that all energies would lead to the same attenuation. So neither of this is true. We don't have a single energy. As I said before, your X-ray source, your vacuum tube, is sending out a whole spectrum of X-rays, and the attenuation is depending on the energy, so of the photon, so on the wavelength of the photon. So now actually the classical CT scanner just ignores this. So that of course leads to some artifacts potentially depending on what you're using as energy range. But what you can do now is you could also try to exploit this. So the fact that you know that there's an energy dependency of the attenuation, and that is different from different atoms and different materials, what you can do is actually you can try to exploit that. And so one way to do it is to make it kind of in brackets simple, is that you do, for example, 2 scans at 2 different energies. And with classical equipment, what you can do is you can just change the setting of your X-ray tube. So what I told you before is if you change the voltage over your X-ray tube, if you reduce the voltage, you will reduce the energy. And so this way, you could actually scan with 2 different kind of energy distributions and then try to compare. So that's one thing to do. Or it can be that you really use 2 sources. Or it can be that you use 2 detectors with a different sensitivity for certain energies, so that you filter out in some ways. Or the ideal way to do it is that you really can analyze or measure each individual photon and determine its kind of energy. And so that's the ideal way, but as we said before, the technology there is only being developed there. Right? So, and by doing that, what you then can do is you can actually get kind of two images where you have, for every pixel or for every point in space, you have these two values or two measurements of attenuation at different energies. And so that makes it easier in some way even to kind of discriminate different types of tissue. For example, to look at calcium or bone, so whether you have bone or calcifications which are induced by atherosclerosis or whatever, like while the composition is slightly different, with a classical scanner we don't see the difference. With a dual energy you might be able to get the difference. So these are ways to discriminate more the tissues. Disadvantage, of course, is that this is based mostly on two scans or combining two scans, so potentially you have a higher dose. So you really have to take that into account. And also, it always complicates things and so on. So that means that currently this is not common, this type of scanner. So these are kind of special scanners for special applications. Okay. So when we look at the images that we can produce, as I said before, so this is a typical cross-section of the thorax that you do. But one of the things is that when you want to scan a patient, so it said like, for example, the doctor can prescribe to the radiologist and say like, okay, I want a CT scan of the whole heart of this patient. So what you then do is then, of course, the technician that is doing the scan, they need to position the heart. They need to know where is the heart. And you have to scan from the top of the heart to the bottom of the heart. Now you could roughly say like, okay, I mean, it starts at the neck and it stops at the abdomen, but that means that you likely scan too much. And you, of course, you don't want to scan too much because that's actually more radiation. So that's radiation for information that you're not using. So what happens is that with these CT scanners, what they do is they actually do first like a scouting scan in some way. So what you now do is, of course, if I take my CT scanner and instead of having the source let it rotate the whole time, if I stop the source, but I do move the table, so I have the source which I let stop rotation, and then I let the patient slide underneath the source, and I measure and I look at the projection, then obviously you have a classical X-ray scan. So with a CT scanner, you can make a classical X-ray scan, and that's what they do first. So they would first make a classical X-ray scan like this, and then they would indicate, say, for example, from this slice to this slice here, this block, I want to scan in 3D. Then they program the scanner, and then the table would be set in such a way, or the width of the beam would be set in such a way that that's the only thing you scan, and there you make the cross-section. So that's how a typical exam would be. Here are some other examples. So here's an example of a brain scan of a patient that had probably a rupture of an aneurysm in the brain. So, and you see here is like a large bleeding, a large hemorrhage. So what you see is like when I look at these brain images, so first of all, obviously you see the skull very well. So that is obviously calcium. You see then also the skin a little bit, and in between the skin is a fat layer, where we said before fat is like a bit darker than the skin and certainly than bone. If you look a little bit lower, you see these kind of black areas in the brain. So these are what's called the ventricles in the brain. So you have a couple of kind of hollow, in brackets, parts in the brain that is filled with fluid. So that's cerebrospinal fluid that is inside in these ventricles. So fluid is dark. And what you now see is that, and one of the things is also on CT, you don't see the difference between white and gray matter in the brain. We will see one of the next times that when we use magnetic resonance imaging, you do see the difference, but on the CT you can't. But what we see here now is that there's like a kind of lighter part that's here. And so this is actually a bleeding. And you know, if there's a lot of blood, and especially after a while, it can become kind of coagulated. Blood has, of course, a lot of iron inside. So blood will attenuate a little bit more than, or at least static blood, which is accumulated there. So you will have a little bit more attenuation as compared to the normal tissue, where you had this bleeding, and this way you can see it actually. Here's an example of like abdominal scan. So here you see a normal liver. As we said before, it's at the other side because you look from the bottom instead of from the top. So here clearly again, you see the spine, you see the bone of the spine. You can also nicely see that the middle of the vertebra is actually less dense than the side. So that's what's called this trabecular bone. So when you take bone, what you have is that the inner part of the bone is much more spongy than the outer layer, and you can very nicely see that on these scans. So here, these white parts are of course still ribs that you cut through. So, and then you see this large homogeneous organ, that's the liver, and here you see air within the bowels. What you now see here is like, and also one of the things that you see is that the liver and muscle have very similar appearance, and that's what is normally the case. What you see here is you see a liver which is actually darker than the surrounding tissue, so that means that actually its composition has changed. And what we said before, as you can see here also, so fat has less attenuation. So when a liver becomes fatty, of course, on average, its attenuation is less than a normal liver. And so this way you can actually partially use this kind of appearance in order to make a bit more of a diagnosis. So again, you do tissue characterization based on trying to interpret the values of the X-ray attenuation that you measure and compare it to different types of tissues that you actually know. So then a thing which is used a lot with X-rays, as we said before, is contrast agents. And typical contrast agents for X-ray is iodine. So anything which contains iodine. So many CT scanners are done with contrast. So that means that they inject iodine-based contrast in a vein, and then they look at the distribution. So you inject it, and then you do the scan right at the moment that the contrast went to the part that you're interested in. Here you see actually a time sequence of this. So these are 3 different scans of the same patient, which has been taken at 3 different moments. This is before the injection of contrast. And you see, for example, if we look at the kidneys, it's very similar to muscle. So this is the muscle at around the spine. The kidneys have very, very similar appearance. Here again, there's gas in the bowels. And one of the things that you also see is, for example, when we look at this structure here. So this is a circular structure, which is very close to the spine. So when it is this ideally circular, it's like, or it can be a nodule, but for the rest, in a normal body, you don't have a lot of ideally circular structures, except blood vessels, of course. Blood vessels have a circular cross-section. And so what you see here, this is a large blood vessel, and this is actually the aorta, because we know the aorta comes out of the heart, so that's your main large artery in your body, comes out of the heart, goes up, and then makes a bend, and then goes down by the spine. So besides the spine, we have a large blood vessel that goes through from the top of your body to the bottom of your belly. So this is the aorta, and you see the blood in the aorta has actually a very similar attenuation coefficient as tissue. So you can't discriminate these. So if we now inject contrast in a blood vessel, what we start to see is that what you see now is that this aorta and surrounding blood vessels become white. So that's because the contrast is in the blood vessels. So here you see that now this structure is white, while it is very unlikely that it's bone. So we don't have a kind of bone with a circular cross-section that is in the middle of our body. Here we know that these are cross-sections of ribs. So this is bone, but this is of course contrast that is being used. And what you now also see is that the kidneys, and especially the outer part of the kidney tissue, also became bright. It's of course because kidney is hypervascularized, and also the kidney is of course the organ that will have to take out the contrast later on. So what we see there is so that in the initial phase, we start to see a lot of contrast, so a lot of blood within the vessels and within the highly perfused organs. And you start to see also some contrast in some other organs here. And if we then wait a little bit longer, what we now see is that the contrast is out of the aorta. So there's almost no contrast anymore. Maybe it's still a little bit, but it's almost the same gray value as initially. But what we see now is that there's white here in the middle of the kidneys. And this is, of course, your urine channels. So what happens is that the kidneys have now taken out the contrast out of the blood, and it's actually being put into the urine. And so you see here that there you get the contrast. So this shows you that depending on when you do the scan after the injection of the contrast, of course, the contrast will be somewhere else. So you can use this contrast dynamics in order to look either at some kind of perfusion or function, or seeing whether what you normally expect, for example, whether that's happened. And very often what we want to do is use contrast, for example, to try to discriminate highly vascularized tissue from less vascularized tissue. And so here we have a scan of a liver of a patient where we clearly see a large abnormality in the middle of this liver. This is not normal. You don't expect this. So this is likely a tumor. And you now want to know what type of tumor this is. And especially what you want to know, is this a dangerous tumor? So is this a malignant tumor? Or is this, for example, more like a fatty tumor, which is not kind of, which is like benign, right? So which is not that bad. So what you then do is you kind of inject contrast. So you see here, again, the aorta is brighter than before. You nicely see the blood vessels in the liver also that contain contrast. And what you see now is that this lesion does not contain contrast. So that means that there's not a lot of blood vessels or even no blood vessels going through this. So that means that it's highly likely that this is benign. Because if it would be a tumor needs a lot of blood in order to grow. So that means that this is likely a normal part. While this is another patient, and what you see here is now after contrast, what you see is that this lesion captures a lot of contrast. And when you compare this, or when you would do like a very detailed histology here, this is actually later on a detailed histology. You see here individual blood vessels. So you see there's a huge amount of blood vessels in this structure, and there's nothing in the middle of it. So this is a very, very aggressive tumor. And so an aggressive tumor needs a lot of blood and is actually growing so fast that the blood vessels can't follow, and that inside the tumor, you don't have blood vessels. And then you start to see that there's necrosis inside, and there's a lot of very highly perfused tissue around. So by looking at the dynamics of contrast, so looking at whether it's like a highly perfused organ or region, yes or no, we can kind of discriminate some of these types of tumors, for example. One of the things that you also can see is that, well, CT by definition makes cross sections, because it makes cross sections where you go through the body with your X-rays. Now, when we look at a CT scanner, what we can do is very often the whole CT scanner can, for example, be put under an angle. So that means that we can make a cross section, either like a perpendicular cross section through the body, or maybe a bit of an angled cross section. But of course, if we have enough slices and these slices are close enough together and the X-ray was thin enough in order to generate relatively thin slices, what we can do is then, of course, we can kind of reformat, resample the data set, and then look virtually in another direction. And that's actually what's being done with most scanners. So once you have all the slices together, you make a stack, and then with image processing, you can go through it and you can see it in different directions. So this would be like corresponding to then a horizontal slice. So it's what they call like a coronal slice instead of an actual slice. And you can nicely see again here the whole lungs that are being shown here with the different airways predominantly in the lungs. Here's another example. That's also what I showed you before. Is like, because of the fact that CT works with X-rays, it's very good at detecting bone. And so here's an example of a baby with like an abnormality where the bone becomes too porous, And so they need to do surgery in order to reinforce this. And so you can very nicely make 3D reconstructions of this bone very, very easily. Okay, so now the fact that we have this possibility to look at contrast, so what I told you before already is that when we inject contrast, of course, the contrast comes first in the blood vessels and comes predominantly in these blood vessels. So we can actually use contrast imaging in order to specifically look at the blood vessels. So what we do is if we inject contrast there and we then, after injection, quickly do a scan at the moment that the contrast is being distributed within the blood, but still not being taken out by the organs. So what we then can do is we can nicely make cross-sections. And if we make one cross-section, what you see is, of course, you see a cross-section through the different vessels. So here you see we go through the aorta. This is also part of the aorta. So you cut it twice, of course, at the level of the heart. You see blood within the heart, you see it's bright. And then within the vessels of the lungs, you see blood. But what you want to do is, of course, get an idea of these vessels. And so what we do here is this is what is being called a maximum intensity projection. So what you do is you take a scan, and then once you have all these kind of white dots here, so what you do now is you now actually make a new projection. And now you go through with a scan line. So you virtually calculate what is the highest value on this kind of path. And you do that for all the lines. So you call this like a maximum intensity. You look at the maximum intensity and you only keep the maximum intensity with your projection. You don't take an average of the projection, right? Because a real X-ray scan would take the attenuation of all the pixels. What you do in the maximum intensity, you virtually go through all the pixels and you just pick out the one with the highest value. And then you can make this type of images where you clearly, nicely see all the vessels. So you see here, for example, contrast in the heart, contrast in the aorta. And what you see here is this is an aorta where normally a normal aorta would be kind of smooth and would be tapered. So that would just slowly become smaller and smaller whenever the side branch is coming. And then later on split into the two iliac arteries, as we say, so going to the two legs. But what you see here is that there's a sudden change in the diameter. So here it becomes suddenly smaller and then becomes thicker again. So this is clearly an abnormality. So this is based on large atherosclerotic plaque that is being accumulated there. So the diameter of the aorta is partially changed because of this. And you see all the nice different vessels, of course. And you see here, for example, the kidneys, which, as I showed you before, they have a higher perfusion. And so you would see a bit more. You can actually do 3D renderings of this. So if you render it with the highest intensities, you can nicely see these organs. You obviously see the bones. So it's very difficult to go out of the bones. And here, for example, also what you see here is this seems to be an organ that captures a lot of contrast. And when you think about it, what is there in very low in your pelvis? That's of course your bladder, so your urine bladder. So what happens is the kidneys, and you see from the kidneys, you see here these things going towards the urine bladder. So the kidneys take out the contrast of the blood, and then it's being accumulated in the bladder until the patient goes to the toilet and then excretes the contrast, of course. Here is another example of an angiography. So here again with contrast, you now see the aorta. But what you now see is that the aorta, instead of narrowing, you see like, it looks like here the aorta splits in two. And this is what is called an aortic dissection. So what has happened here is that when we look at the wall of the aorta, so every arterial wall, so an artery, which you probably know from anatomy, consists of different layers. So you have like an endothelial layer, then you have like a smooth muscle layer, and then you also have like a structural layer. So what happens is that actually in some patients, what happens is that several layers start to separate and you actually get blood in between these layers. So that's called an aortic dissection. And so CT with contrast is the typical way to look at this. So you see here again, so you see that the real aorta is becoming compressed, it's very, very small. And this is what we call like the false lumen. So you see there's a bit less contrast going there, but still there's contrast here. So, and this is of course a very dangerous situation because dissections of the aorta have a very, very high mortality. You can already see partially why a patient like this could have this aortic dissection, because when you start looking here at the aorta, what you see here is you see these very bright spots at the site of the aorta. You see at several points, you see these very bright spots. And the brightness of these spots is similar to the bone. So this is actually calcification. So this is a patient that had a lot of atherosclerosis, which is then calcified, and obviously calcification, calcium, will be very bright on X-ray imaging, and so you really can look at calcification of vessels with a CT scan, for example. Here is an angiography of a brain. So here is actually, so you see the different vessels of the brain, and what you actually see here, and that's like isolated here. So this is like a large aneurysm, so of the brain, which is of course quite dangerous for having like a rupture of an aneurysm and then having a bleeding. So have a hemorrhage and a stroke. So this way you can actually also image these things. Now, we can actually also use CT, and especially when we use filtered back projection for quasi-real-time imaging. So we can actually also do interventions under a CT. So, and typical is doing biopsies, for example, or draining of some kind of fluid cysts. And so here would be a typical CT scanner. So what you see here is this is the tube or the opening of the scanner. So in between here, you will see that there is the rotating here inside. You have the rotating X-ray tube and detector that rotates fastly around the patient. The patient is on the table, can go through here. You see here is an operator, and one of the things that you also see is that this operator is wearing this kind of special kind of skirt-like or jacket, and also something special around the neck. So this is of course protective dressing. So this is like lead clothes, or clothes that have layers of lead in order to protect the operator for the X-ray radiation. So, and then you see a setup, so where we can work at the patient, and then you see behind glass, so in the operating cabin, so where you look behind lead glass, that's where the one that operates the machine is. And then what you can do is, so you can see here, this is, for example, a lesion with fluid. So what they do is they enter a needle there. So you see the needle is very, very bright on the scanner because it's of course metal, and then they can drain the water out of it, so they can take the water out of it. So here you see it, and so you see here before and after the draining of this. So what they do is this fluid, they take it out, they bring it to the lab, of course, to see whether this is malignant. So this is both therapeutic to get the liquid out, and secondly also it is diagnostic, because then you can do microscopy of the liquid. So that you can do, just like I showed you last time with ultrasound, you can do a biopsy. You could actually also do it guided by CT. Okay, so briefly before we do another break, talking a little bit about image quality and some artifacts that we have. So obviously the image quality depends, first of all, on the scanner. So, and that depends on the shape of the X-ray beam in some ways. So how small is the beam? How many problems are there with the beam? What are the detectors like? So what's the size of the detector? Do I have a big integrating detector? Do I have a small detector? And detectors that are next to each other, can they discriminate it well? Are these detectors positioned ideally with regard to the beam? And do we know this, or is this wiggling, for example? So also the rotation, is the rotation done properly? The mechanics around this. So all these kind of things are related to the scanner in some way. Then beside the scanner, of course, we need to do reconstruction. And as I said before, reconstruction can never be ideal. So that means that there's always also some potential problems. How much time we spend in the reconstruction, how large are the pixels that we make. So all of this will change the resolution kind of regularly. And as we said before, roughly a CT scanner has a resolution of roughly 0.5 millimeter. That's the best we can do with a CT scanner. So next, there's the noise in the images, and the noise is very much related to the amount of photons we have. So because of the fact that these photons are made by, first of all, made by a non-ideal source, which is some way stochastic, and then also the interaction, the absorption is, of course, in a way a stochastical thing. Does the X-ray come to an electron, yes or no? So that means that there's some intrinsic noise. And then also there is the noise from the reconstruction again. So where we need to do some interpolation or something like that. And so very typical artifacts that we have is this kind of streak artifacts. So where if we have a very highly absorbing, for example, a metal prosthesis surrounded by soft tissue, we very often see this kind of streaks. And only with iterative reconstruction we can get some of these out, but very often we still see them. So this is very typical. So this is not because of the fact that this body has these streaks inside, but is of course because we have this huge difference in sudden attenuation coefficients, and that will depend on that. The contrast that we get depends partially on the spectrum, as we said before, on also how we display the image. So since we have a very high range of attenuation coefficients that we measure, we partially show something or the other. So in some ways, we virtually choose the contrast that we want. And sometimes we do kind of external, like iodine contrast, in order to change this. So there are a couple of these artifacts, and as I said before, artifacts are most often related to the fact that you have these very highly attenuating things together with the others. But all of these things can change, can kind of change the image. As we said before, an artifact can be from noise, can be a sampling problem, can be, as we said before, the fact that there's a energy depending attenuation where soft X-rays are actually attenuated more than hard X-rays, so that also makes a difference. We have the scattering, so where we have X-rays passing through and then changing direction. So obviously they will come on the wrong detector and we think that they come from a wrong line. So that also, of course, also gives artifacts. So all of these things give typical artifacts that we will get there. And here you see an example. So you need to know that these are artifacts, because here, for example, you see a reconstruction of a skull, and it looks like the skull has these kind of rings on it. Obviously, this is not true. This is not the anatomy. This is an artifact which is caused by the acquisition, and especially also these streaks. So these are artifacts that we really have to know when we interpret it. And also when we do further processing, we have to make sure that we keep in mind what the artifacts would be. So, as I said before, for example, metal gives a lot of artifacts. And here it becomes important when we interpret it. So here, for example, we see we have a metal hip. So this is a hip prosthesis. And it looks like it's dark surrounding this. So the question is this gas around it? Because we know that dark should be gas, but it's extremely unlikely that there's gas there. So this is an artifact that we have to keep in mind. And typical ways to do that is, for example, measuring phantoms. That gives you how a real scanner would give. And so by doing, as we said before, iterative reconstruction, we can actually compensate from that. As I said before, here is a typical scanner. I'm not going to go in detail. The typical setup where the operator is protected by lead glass and the patient is sliding through this tunnel where inside we have the X-ray tube going on. There are a couple of special scanners. For example, a head scanner, which is mainly for when you go to the dentist, you need a prosthesis. Then we have like a special CT scanner for the teeth. We have some special CT scanners for breasts, which only would rotate around the breast. And there's a couple of CT scanners that you can open up and then use in theater. But all of these, especially these are, so these are very typical. You see these for typical applications. So these are kind of dedicated purpose scanners, and these are more like experimental scanners.